Hello everyone, welcome back to another surgery video. Today, we'll be covering everything you need to know about laparoscopic cholecystectomy. There's so much information that we need to cover, so let's go ahead and dive in. The first thing I want to cover is the anatomy of the gallbladder and biliary tract. So let's start with the gallbladder. Right here we have the fundus of the gallbladder, the body of the gallbladder, and then the neck of the gallbladder. And then the duct coming off of the gallbladder is going to be called the cystic duct. It meets the biliary tree. The biliary tree is made up of the left and right hepatic ducts, the common hepatic duct, and then we have the common bile duct. If we go ahead and move inferior to what we just covered, we're going to find where the pancreatic duct and the common bile duct meet is called the ampulla of Vater. There's a small little muscle that acts as a sphincter that opens and closes this ampulla, and that's going to be called the sphincter of Oddi. And like I mentioned earlier, right here we had the pancreatic duct, which then meets with the common bile duct. These are some surgical landmarks that you have to know if you want to learn more about cholecystectomies. Let's start with the hepatocystic triangle. The hepatocystic triangle is obviously a triangle that has three different borders. The medial border is made up of the common hepatic duct, the superior border is the inferior margin of the liver, and the lateral border is made up of the cystic duct. You might also be asked about this yellow triangle called Calo's triangle, and it's made up of three borders as well. The medial one being the common hepatic duct, the superior being the cystic artery, and then the lateral border being the cystic duct. I've also included an additional landmark that's commonly asked by surgeons, and it's this yellow circle. I have a red arrow pointing at it, and that's supposed to indicate a lymph node that's found right around or even on top of the cystic artery, and that's going to be either called the cystic lymph node, or I've also heard it be called Calo's node because it's found within Calo's triangle. Here's some abnormal biliary anatomy that's crucial for you to know. Right here, you can see some accessory bile ducts that are abnormal. Usually, you don't have ducts that come from directly from the liver straight into the gallbladder, but it's important that you need to know in case you have a biliary leak. Those accessory ducts are called ducts of Luschka. Again, this is abnormal anatomy, and there's multiple variations of these ducts of Luschka, but it's important to keep those in mind when performing a laparoscopic cholecystectomy. Here's just your general liver anatomy. Of course, you have your left and right lobes, you have your falciform ligament, you have your hepatic artery, hepatic vein, and biliary duct, and then you have your gallbladder found in the gallbladder fossa. Now, a common question that you might be asked is what is the division between the left and right lobes of the liver? And you might be tempted to say the falciform ligament, but that is not the case. What you do is you find the inferior vena cava, you find the gallbladder and the gallbladder fossa, and you draw an imaginary line between the two. And this is called Cantley's line. And this is the landmark that you'll use to delineate between the left and the right lobes of the liver. These are the segments of the liver. There are 8 of them, with segment 4 having part A and part B. Now, this might be overwhelming and difficult for you to memorize, but there's a trick to memorize these segments. And what you do is you grab your right hand, you tuck your thumb behind your other 4 fingers, and there you go, you have the segments of the liver. Just remember that you have segment 1, which is your thumb, then you have 2, 3, 4A, 4B, and then going clockwise, starting at the bottom knuckle of your ring finger, you have 5, 6, 7, 8. And there you go, you've memorized all 8 segments of the liver. It wouldn't make sense not to know the different types of gallstones when you're helping with a cholecystectomy, so let's quickly review those. Cholecysteitis is the medical term for stones within the gallbladder. 10 to 15% of the population has gallstones, but the majority of them are asymptomatic. There are 2 types of gallstones. You have cholesterol stones, which makes up the vast majority, up to 80%, and that's associated with obesity, pregnancy, weight loss, and different medications. And then the second type of gallstones you have are pigmented stones, which can be broken down into black and brown stones. Black stones are radiopaque and are associated with hemolytic diseases, such as sickle cell disease. And then you have brown stones, which are radiolucent and associated with gallbladder infections. Here are the different risk factors that can predispose you to develop a gallstone. Obviously, this doesn't apply to every patient, but these are just good general guidelines. You might have heard of the female fat 40 and fertile mnemonic. That's just a quick little trick that med students have come up with to help remember different predisposing factors of gallstone formation, but is not a set rule. Some predisposing factors that can lead to gallstone formation include family history, female sex, diabetes, metabolism disorders, both obesity and rapid weight loss. And then if you have high amounts of estrogen, whether it be pregnancy or estrogen-based therapies, can cause biliary stasis or decreased biliary secretion from the gallbladder, which then can form gallstones. And then different medications also predispose you to gallstone formation, which are GLP-1s, fibrates, and estrogens. A very common question asked to med students is if you have a pregnant patient come in who has all the signs and symptoms of acute cholecystitis, do you perform a laparoscopic cholecystectomy? And the answer is yes, you absolutely should do a laparoscopic cholecystectomy. Then the follow-up question to that is which trimester can you perform this procedure? And the answer is all of them. So SAGE's guidelines recommend that pregnant patients who have acute cholecystitis should not undergo non-operative treatment, but should have early laparoscopic cholecystectomy, just because having acute cholecystitis carries high risks of preterm labor, and it's also associated with fetal demise. So it's important that these patients undergo laparoscopic cholecystectomy instead of treating them non-operatively. Okay, now let's cover some classic biliary pathologies. We already covered cholelithiasis, which just means you have stones in the gallbladder. But then you have cholecystitis, which is inflammation of the gallbladder, usually caused by stones. Patients will present with right upper quadrant pain after eating fatty meals. You'll have a positive Murphy sign, which I'll describe in the next slide. And then they'll also be febrile and leukocytotic. Choledocholithiasis, which just means a gallstone within the common bile duct, can cause complications as well, obviously. And if it goes untreated, you can have cholangitis, which is inflammation of the biliary tree, and that has its own signs. You might have heard of Charcot's triad, which is right upper quadrant pain, fever, and jaundice, just because you have that biliary backup because the common bile duct is being obstructed by a stone. And then if you add hypotension and altered mental status, that becomes Reynolds pentad. So those are some signs that you want to look out for in these different type of patients. So what is Murphy sign? Murphy sign is not right upper quadrant pain. Murphy sign is when there's pain elicited with deep palpation in the right upper quadrant along the midclavicular line, and it's usually done by palpating deep underneath the right subcostal margin. And then you have the patient taking a deep breath. A positive Murphy sign occurs when a patient abruptly halts inspiration. So you palpate deep underneath that right subcostal margin or along the midclavicular line. You instruct the patient taking a deep breath. And if they abruptly halt due to pain, that's a positive Murphy sign. Another finding that you can see is Boas sign, which is just hypersensitive to pain or just pain over the right infrascapular or interscapular region on the right side. And that's caused to a very sensitive phrenic nerve due to gallbladder inflammation. Some things you want to do for your diagnostic workup is, of course, imaging. Ultrasound is king. It's first line. It's highly specific, highly sensitive for cholelithiasis. Some findings that you can see under ultrasound is gallbladder wall thickening, if it's greater than 3 to 5 millimeters, pericholecystic fluid, and then you can also have a positive Murphy sign when the ultrasound tech is pushing the probe underneath that subcostal margin towards the liver. You use an MRCP or ERCP when ultrasound findings are equivocal. Remember, ERCP is both diagnostic and therapeutic and is used to remove any stones found within the biliary tract. When you're drawing labs, of course, you want to draw things like your CBC, your CMP, but when it comes to LFTs, you want to look out for elevated ALP. Remember, ALT and AST are markers of hepatocellular injury, which is commonly indicative of liver pathology. And ALP, which is found within the bile duct epithelium, is most likely associated with gallbladder or biliary pathologies. And then with that, you have bilirubin levels. I've been asked at what level of bilirubin do patients have scleral icterus? And the answer is 2.5 milligrams per deciliter. And then their skin becomes that mustardy yellow color when bilirubin levels are at 5 milligrams per deciliter. This table is from the American Society of Gastrointestinal Endoscopy, and it helps us evaluate the risk of choledocholithiasis when patients have symptomatic cholelithiasis. So we know they have stones in their gallbladder. What is their risk of having choledocholithiasis? I'm not going to go through every point found on this table, but essentially you just look at the different criteria, and if they fall within high or intermediate and low, you can then use this flow chart to help your decision making for the management of this patient. It is critical for you to know the Tokyo guidelines for acute cholecystitis. You can find these guidelines on MD Calc. So when you're rounding on a patient who has acute cholecystitis, you can use these guidelines to plug in and see what stage of severity they are. These are the criteria found in those guidelines. If they have a positive Murphy sign or right upper quadrant pain, if they're febrile, elevated white blood cells, you plug all these in within the MD Calc for the Tokyo guidelines, and then it will give you a grade. And then based off the patient's grade of severity, you can follow the recommended management. Just remember, if they're in a severe grade or grade 3 and they aren't suitable for surgery, then the patient will have to undergo a percutaneous cholecystostomy tube, and they'll have to drain the gallbladder because they aren't fit for surgery. So right here is my own little creation. This is the flowchart that I made. I've incorporated both the Tokyo guidelines as well as the American Society of Gastrointestinal Endoscopy. I pulled their table, kind of condensed it into a smaller table, made a flowchart out of it, and this has helped me with decision making on what form of management the patient should undergo. So feel free to screenshot this or to put this in your notes. These are some other surgical indications for cholecystectomy. Obviously, symptomatic cholelithiasis, acute cholecystitis, choledocholithiasis after the duct has been cleared, gallstone, pancreatitis, biliary dyskinesia, gallbladder polyps. If they're greater than 1 centimeter, that's a concerning feature because it could lead to gallbladder cancer, as well as porcelain gallbladder is usually associated with gallbladder cancer, so we want to remove that as fast as we can. Excellent. Now we can get to the fun part. Surgical management. That's why we're here. We want to learn about the surgery. It is critical that you know the critical view safety, which was established in 1995. In order to accomplish the critical view safety, it involves completing 3 steps before any structure is altered, cut, or removed, and it has to be completed in this order. The first thing you need to do is clear out the hepatocystic triangle from all fatty or fibrous tissue. Then you need to identify 2 distinct structures entering into the gallbladder, which are going to be the cystic duct and the cystic artery. Then you need to separate the gallbladder from the gallbladder bed of the liver, the lower third of the gallbladder from that gallbladder fossa of the liver. Once the critical view of safety has been made, you then need to identify all B-safe structures. The B-safe structures, so B-safe stands for bile ducts, sulcus of Rovere, the arteries, specifically the left hepatic artery, the umbilical fissure, and then all enteric structures. Once both the critical view of safety and the B-safe structures are found, then you need to make the R4U safety line. This is an imaginary line that you make that connects the sulcus of Rovere, the 4th segment of the liver, and the umbilical fissure. You connect all those dots to make a straight line, and anything superior to the R4U safety line is safe for dissection. Anything inferior to that is dangerous and shouldn't be messed with. Here's this beautiful image that demonstrates everything that I just covered. So we have our critical view of safety. We've established the B-safe structures, and we've made the R4U line. So with all these boxes checked, we can confidently and safely go ahead and cut the cystic duct, the cystic artery, and remove the gallbladder. If the surgeon suspects that there's a stone within the common bile duct, more often than not, they will perform an intraoperative cholangiogram or an IOC. What that entails is that a small cut is made into the cystic duct, and then a catheter is placed within that little incision. Contrast is then pushed through that catheter, and it should illuminate all the different structures of the biliary tree under X-ray using a C-arm machine. If contrast doesn't make it into the duodenum, or we can't see the complete biliary tree, then we can be confident that there is indeed a stone that's causing an obstruction. If there is a stone, and we do see choledocholithiasis under this form of imaging, the surgeon, more often than not, will push glucagon or ask glucagon to be administered into the patient. And what glucagon does, it relaxes that sphincter of Oddi that we talked about, and hopefully we can flush out that stone and not have to undergo ERCP. Here's an AI rendered image of a IOC. It's not the best image, obviously, because it's AI, but you can kind of get an idea of how the cholangiogram enters into the cystic duct in order for the contrast to be flushed inside the biliary tree. Here's an image from an IOC. You can see all the different structures, and you can see that the duodenum is illuminated, and so we can be certain that there's no stone within the common bile duct. If the surgeon is using robotics when performing laparoscopic cholecystectomy, they can use an alternative form of intraoperative imaging. They use what they call a Firefly fluorescent imaging. When the patient is in the pre-op area, they're administered indocyanine green or ICG dye. And this dye is very lipophilic and binds to albumin and different lipoproteins. And then it's taken up by the liver into the hepatocytes and then excreted into the bile. And then with the robot, they use the Firefly, and it causes this fluorescent look, and they can identify all the biliary structures. And this ensures a safer procedure and you don't run the risk of damaging the wrong bile duct. Some additional gallstone pathology that I want to review. The first one being emphysematous cholecystitis. And this is just a severe form of cholecystitis that has progressed into a gangrenous gallbladder. It's characterized by gas within the gallbladder wall or in the lumen. If a patient has emphysematous cholecystitis, they are very, very sick and they run the risk of perforation and being septic. And so this is a surgical emergency. Management is using IV antibiotics plus one of the two options, obviously a lap chole when feasible, but they aren't able to undergo a surgery. You use a percutaneous cholecystomy tube to drain that gallbladder. The next one I want to cover is called Merizi syndrome. This is a fascinating gallbladder pathology that I find super cool. It's when a gallstone is found within the cystic duct, and it's so large that it actually obstructs the common hepatic duct, which then obviously causes biliary backup. This is treated through surgical management and often requires a subtotal cholecystectomy and biliary reconstruction compared to your just run-of-the-mill lap chole. Here's an image of Merizi syndrome. And then you have gallstone ileus. Gallstone ileus is when there's a cholecystoenteric fistula formation between the gallbladder and the duodenum. And what happens is a gallstone passes through that fistula and then causes a small bowel obstruction at the ileocecal valve. If a patient has gallstone ileus, look out for that classic Wriggler triad, which is small bowel obstruction, pneumobilia or area within the biliary tree, and then the ectopic gallstone. Management for this is surgical interlithotomy, and you can go ahead and proceed with a cholecystectomy and fistula repair. This can be at the same time as the interlithotomy, or it could be a delayed procedure. These are the landmark papers that I recommend all students that are going to go into surgery read. It is critical for you to know all the information found within these papers. It'll review the critical view safety, the R4U plane, the Be Safe structures, and then I'll also review SAGE's guidelines. Especially when you are dealing with pregnant patients, it's good to review the guidelines that they recommend. And that concludes my video. I know it's a lot of information. Feel free to screenshot or use any of the notes that I have provided. And as always, study hard and good luck with your surgical journey.